Welcome to Life Sirens, behind and on the scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations. Get fucked.
Literally get
You're done.
fucked.
Get fucked.
You're done.
Okay, if you think you should be using Sucks over Rock because it wears off faster, no. I'm so sorry.
No.
That's
Sign
not
your name on anything.
that's not the
then.
reason. You shouldn't be intubating them
You're scared.
because
You should not have a paralytic if that's why you... Yeah,
No.
no.
And also, you've made the decision that no matter what happens, a tube is going into this person and you're going to breathe for them. Because
Mhm.
that's what happens when you RSI. You've decided, even up to the point of me slicing their neck open,
Yes.
I will be breathing for them.
This is my
Who
only option.
The F cares how long your paralytic lasts if you
Mhm.
have sedation, which obviously you do.
And especially in the realm of flight.
Obviously, yes.
Also,
You want them paralyzed. Honestly, like if you're intubating somebody and
Oh my
they're
god,
flying,
we have to paralyze people
you
all the
want them
time.
paralyzed.
Yeah.
It's the safest way to transport them.
Yes.
and I would
absolutely.
just like to point out that, like, okay, we hear that argument all the time, as invalid as it is, that, like, Sucks doesn't last as long, so, like, if you don't get it, it's better or something, question mark. But raise of hands of how many people have seen somebody give a paralytic
Just
and
be
then
like,
just be
"Nah."
like, well, all right, well, we're just going back for the next 5 minutes. Like, when have we ever seen that? I've never
Yeah.
seen that one time.
And I think
That's it.
I
That's
understand-
insanity.
It's a myth. I'm pretty sure it's a myth.
see, but what I think is it's a doctor argument because doctors do electively RSI patients. They do RSI patients that actually can ventilate on their own.
Okay, but also
for
if you're
different
making the
reasons.
decision
Correct,
to
right?
steal
But I'm-
someone's airway, to steal their breath from them, then you
Mhm.
need to fucking commit, bro.
Right? But they don't want to do that because sometimes it is elective and they were able to ventilate on their own. And so there may be some other options. For us, if we are RSIing somebody in the field, we're out of choices.
I need to ask you, what is the other option? If you think that they need a tube, what is the other option?
Cancel their surgery.
No, but like
Yes.
I'm talking about even like I get that for like ORs, okay.
She said shook it.
Shooketh. I get that for like ORs, but I'm talking like even in the ER. Like
Oh,
I've
yeah.
never seen like, oh, a crash cart's going in. Oh, they're tubing this person, and then just be like, well, guys, that was
Never
a valiant
mind.
effort, but we're just gonna sit here and bag. Like,
Yeah.
no, never, not one time.
If
Yeah, you're
somebody
right. Yeah.
knows, please tell. I cannot conceptualize
what are we doing?
that. I can't.
Yeah.
Because, listen, guys, what? You're going into intubate.
Yeah.
You're going to make sure that they are unconscious and paralyzed. That's how bad they need an airway.
Mm-hmm.
That's how serious it is.
Yep.
And that we always say this, if you're going to RSI them, you have to be prepared
Yep.
to correct them. Why would I be prepared to correct someone if I'm just going to let it wear off
If
and
I'm
be
just
like,
gonna-
never mind?
Right? And where's that line that you're just like, well, throw in the towel.
It's not real.
Yeah. When are you
I
like?
don't think it exists.
When are
don't
you like?
think
I
so.
can't
That's a
get the
myth.
tube, so I'll just wait for it to get better.
It's an urban legend.
It has
And
to
I
be.
think I even tried to go down like the Sucks argument. I'm like, okay, you want a paralytic that doesn't last as long. Maybe that way the patient's like reflexes are back. I don't know. You think that will be better for them in some way? Like, fine. But any kind of like hemodynamic stability that you're seeking by not having a paralytic on board is one, negated with Sucks and vesiculations in the first place.
Yes.
But two, you can fix that chemically.
Also,
Like you
it's
can
a
give
crash airway.
pressors. You can give meds to
yeah.
fix these issues. So like just use
It's
fucking
made
rock.
up. I'm convinced.
I
Okay.
agree. Okay, we got on a bit of a tangent, but then that leads us back to why don't we get ketamine drips?
Yes, why don't we?
Like, why is that a thing that y'all have ever heard of? Like, maybe immediately on getting the tube, you hang a ketamine drip.
Yeah.
It is
Yeah.
like it's protocol some places.
yeah.
Oh hell yeah.
We can do that.
Y'all can.
Yeah.
So why is that not like way more standard?
I think
I don't
because we
know.
just don't. I think we should teach RSI. Everyone learns RSI, And then instead of it being like the add-on, everyone learns how to intubate with RSI. And then if you don't have RSI, then you do it without RSI.
I agree.
Like,
Because
why
that
do
way you
we-
learn med management and all the things.
Yes.
Honestly, Obs, I think the reason that a ketamine drip post RSI is not standard in the field is it's a horrible reason. I think they're just afraid to tell medics to do drips.
But we have pumps now.
I know.
Like, I get that.
But even that, I think that they're just like, that's math. Don't
They're
just do a
scared
push
of drips,
dose.
but you're just being like, I don't know anything about your medical history or anything. I know nothing, so here sucks.
Right? In my brain, a drip is way more cognitive offload.
Especially now that we have pumps. Like, I can
Yes.
understand, like, okay, I just, this person is down bad for all intents and purposes. I have a lot going on. I just tube this person, and I'm trying to simultaneously drive to the hospital and, like, also fix whatever comorbidity is causing this issue. Like, I hear you, but we have pumps now. Like,
Yeah.
the technology exists. That's
Yeah.
cognitive offload. And now I don't have to think about resedation.
100%. I think it's a great idea.
In the hospital, there's a drug you can reverse rock with.
Yeah.
So, why
So
are they
again,
bringing
why
it
are we
up?
using Sucks? When they're like, hey, there's like 637 side effects that could happen with this drug. But we'll use
Yeah,
it.
let's see. Hyperkalemia, renal failure, crushed patients greater than 24 hours, neuromuscular disease, prolonged downtime, malignant hyperthermia, major denervation injury, known elevated potassium or unknown, pediatric unknown condition. Don't use it in peds. Get away from me. Significant rhabdo risk. And rock is just metabolically safer. Okay,
Yeah, the
it's predictable.
rock side effect list is
We need the longer.
the intended effect.
Correct.
Paralyzation, we need it because it is so hard to keep everything compliant when you're moving them around, okay? And if you're worried about it as a hospital physician, you can reverse it. Also, you can just fucking bag them.
I need you to repeat one thing in there.
Yes.
Malignant hyperthermia. Can you imagine okay, so like let's just say that your patient is like awake and you're able to have this conversation and you sit down with them and you're like,
We
so
need to
here
make this a mini episode.
This is going to turn into the best episode ever.
yeah.
I'm locked in now. You sit down with your patient and you're like, okay, so here's what's going on. I am going to give you this medication. I do need to make you unconscious. However, this medication has the potential
To murder you.
to have you ever been on Thanksgiving and you've tried to cook a turkey in oil? That potentially could happen to you. You might cook from the inside out. Is there anything we can do about it if that starts happening? No, there's not.
No,
Not
there's
here, not in
not.
this truck. No.
No.
Absolutely not.
So
We
we'll
will
get you there as fast as we can.
I have
commandeer-
Tylenol.
I probably won't check your temperature either to
Nope.
be
I
able
have
to
no idea that's
alert.
happening. I don't have the little forehead thermometers that they put on in the OR.
And guys, I
Like,
have
that's
seen
crazy.
this. Not in my patient, but I've seen people go pick up. I mean, freaking, one of our medics did.
Yeah.
He went and picked up a patient from a surgery center who had malignant hyperthermia. And that's a very controlled setting, guys. It was so controlled and so minor that they thought they could do it outside of a hospital.
Yeah, there wasn't even a hospital attached to
Yep.
it. We had to fetch them to take them to
Yes,
the hospital.
Exactly.
Oh
Get
my
away
God.
from me. Don't give me sex. I'll fight you.
We might cook you. What?
Yeah.
No, thank
Everybody
you.
finna be cooked.
Like, hey, you'll either be paralyzed for 30 minutes or you may get cooked.
You
Who
may be
knows?
Thanksgiving turkey dinner.
Gotcha. So your intended effect may last 20 minutes longer with the other medication, or 1,000 unintended effects could cook me from the inside.
I wonder how many old
Mm.
doctors are making mad right now.
No, thank you.
They're not listening to continued
They don't know about.
medication.
They don't know about podcasts.
Have you ever Have you ever read Dante's Inferno? That could be your life.
Have you
be,
ever wanted to
but-
know what the circles of hell felt like?
But I had lacked so much confidence in myself of being able to intubate you that I wanted to take that risk of letting you burn alive.
I wanted you to
Right.
take that risk for me.
Yes.
That's what it is, guys. I want
is-
you to take that risk for me.
Yes.
No, that's bad.
And it is
Don't do that.
100%. It is just, I am scared. And just in case I'm bad at it, we're off.
I don't want to blame myself. I want to blame the drug.
In what
obviously.
other skill can you imagine? Can you
No,
imagine
I literally can't.
pre-hospitally if our like intended rule was like we'll do this 'cause bad at it instead? Like how many times with services that have like gotten rid of intubation and just supraglottics, and the reason is not because it's better for patients, it's because they're bad at intubating.
Yeah.
Well,
They've made up that it's better for patients. But there actually was a study that came out recently that was done in Japan that was like 134,000 patients with pre-hospital intubation versus supraglottic airway. And there was not a change in like neurological survival, but there was a change in like positive ROSC outcomes with like cardiac arrests.
Yeah.
And there was a correlation in neurological survival, but it was
And I
not
don't
like
think
crazy.
it's about how they're like. I get delaying the tube, and that's what they're worried. That is the only thing.
But
they're
there
worried
were
about.
there was significant data that showed that patients that had a ET tube secured had a far better outcome.
This is a whole rabbit hole that we could make a whole separate
know,
mini episode
But
on,
in
'cause
my
I
brain,
love this.
that's the same thing, because you're like, we're bad at it, so we'll just do this kind of subpar one just in case.
Yeah.
Well, we used to have that.
Mm-hmm.
If they were like, if you can't get an IV and you can't get an IO, it's fine. Pour the drugs down the ET tube.
Yeah.
Guys, also,
Yeah.
that's a dumb rationale. Okay, first, let's just say we're not saying sex is necessarily bad, but also, we know that it's rare, the side effects, but also, we literally have to get 12 leads on like 60-year-olds to give them Zofran.
Yep.
Because of prolonged QT.
You can take that at your house.
Yeah. And now you're just like, but
Get
sex
outta
is a better
here.
answer.
Right. Can we
No.
just talk about all the reasons it's bad?
Yes.
Go down the line.
Number 1, hyperkalemia. So sex, it obviously it depolarizes things that its friend rock doesn't.
Yes.
So it causes small potassium rise. It's small, but with patients who are multi-day on burn,
Mm-hmm.
they have crush injuries or have been immobilized or down for prolonged periods of time. They are a stroke patient. They're a spinal cord injury patient or a spinal cord stroke patient, or they have myopathy. That potassium can become lethal.
Yeah, it can
That's
cause
a lot of patients.
Yeah, with your patient, depending on how how unstable your patient is, it can cause a big potassium shift.
Yeah.
And how
Why
often?
would we risk that?
How often do you go to a home where you find an unresponsive granny
Unknown downtime.
who's been in her bed for 4 or 5 days?
She has rhabdo.
Do we
guys.
consider that necessarily down? Maybe not.
I consider that down bad.
Right, we would consider it down bad, but they're not on the floor.
Right.
They're not like,
They're not
that may
stuck
be
somewhere.
a patient that you initially overlook.
As
I
like I
shouldn't.
need to skip sex.
Yes, I should not give sex for this. So if you do choose to give sex, bad news.
Yeah.
How often do you find an unresponsive patient just in a miscellaneous environment where you don't have family to be like,
All the time.
are they
every
on
day.
dialysis? Do they do like, because
Exactly.
you have patients that don't have like huge fistulas and things like that. Like it's just there's a lot of factors
It's a
out
risk
in the
I'm not
world.
willing to take.
Yeah.
If I
Mhm.
am deciding to take your airway, I'm doing the damn thing. Also, we talked about
Yeah.
malignant hyperthermia. I don't know you. I don't know you.
Mm-mm.
I don't know about your genetics.
I don't know anything about you.
I always love with meds when the side effect is like, the side effect is like hypersensitivity to medication. I'm like, how do I know that?
How do I know?
Don't give the contraindication if they have a hypersensitivity to sex. Don't give them sex.
Right. I don't
Ma'am,
know
have you
that.
ever burned from the inside out before? Oh, you're unresponsive as fuck? Okay.
People typically are not walking around this earth being prepared to be RSI'd. So they probably
No, they are not.
they're probably not gonna have
They
a
be
bracelet
eaten.
that says I'm allergic to sucks.
Right? They be eating chili every moment of their life before they go into respiratory arrest.
And they probably also don't know they can't have sucks. They probably just know they had this malignant hypothermia thing,
Mhm.
and they're probably not even going to tell you it right. Okay?
No, they're just going to say they got hot one time when someone gave them medicine.
Yes, I literally just found 1, 2, 3, 4 complete studies for different reasons that you shouldn't. And I just did a quick search. Okay?
I love it.
Prolonged paralysis can happen.
Oh, yeah.
It can.
Because some people don't have the enzyme that breaks down succinylcholine. And if you don't, then you can be paralyzed for a very long time.
And that's
What are we
debatably
saying?
worse.
What are we saying is a very long time? Are we saying like
Hours,
Hours.
days.
hours?
yeah.
Oh my god.
Yeah.
Because it never gets, the enzymatic reaction never happens to
It just has to be
remove
like
it from the
excreted.
synapse. Yeah.
So if the
Mhm.
patient has that pseudocholinesterase deficiency, right? That's what it's pronounced. That is actually what happened to this patient.
Oh, that makes sense.
Yes.
And they had
I
no
do
pain
remember that.
medicine. They were
Mhm.
just literally super freaking aware and just paralyzed after their surgery.
Mm-hmm. That's miserable.
That's way worse, guys. Okay. Then up to 90 minutes, which I have
Never.
That's extreme.
Most patients that I've given rock to showed signs of paralysis wearing off within 20 to 25
yes,
minutes.
absolutely. And that's
Because a lot
great.
of these patients are in a hypermetabolic state.
Uh-huh.
Yeah.
Their bodies are working super
They're-
hard, so they're
they're sick.
metabolizing things pretty quickly.
110%. And then this one is real great. Ready? bradycardia and asystole is a real reported, and I can add all of these to the show notes here. Okay, guys, this is a PubMed article with repeated doses in pediatrics and some combinations of induction agents. But severe bradycardia and asystole have been reported after single doses as well.
I love that.
Get that the fuck away from me.
Yeah, no. And I also am very intrigued. Have y'all seen services that carry Sucks,
This is from
and then in
2021.
the event Sucks is no bueno for that particular
They also
patient? They
carry
carry
Rock.
Vec.
Oh, Vec, yeah.
We have it, but we don't use it.
Yeah.
No one uses it.
There's
That's
a couple
what-
services. Well,
I understand if you have
Yeah.
a wildly long transport time or flight time. I understand why Vec would be useful. You want a prolonged
I
process.
think people keep it too because of its shelf
Yes,
stability.
because you have to reconstitute it,
Yeah.
which we
That's,
learned
Rock
with a
also.
very, very prominent malpractice case. That it has to be reconstituted.
yeah.
Yeah, I just think it's an odd.
I
I've never
just-
one
It's
time.
an odd juxtaposition for
I just
sure.
don't
Yeah.
understand why that is the hill we're dying on, guys.
And again, I think that we have proven
Because you
that
will die on the hill.
you will
Right.
die on
And
the
the
hill,
only-
and I
And
think the
paralyzed
hill's
at
made
that.
up. I think it's a
Yes.
mirage. I think we're in the desert, and
Actually,
it's
you're
all
probably
a
right.
mirage.
And the only pre-hospital providers you find that die on the Sucks hill are ones that have only ever had Sucks.
And they're usually
Anyone that has had Rock will tell you 1,000 times over that they would prefer it.
100%. 100%.
Yeah.
How many times just want to know, how many times have you, if you are a medical director who insists vehemently with no supportive medical context at all that your crews should be intubating with Sucks, how many times have you intubated a patient outside of an OR or a trauma bay? Tell me right the F now.
Yep.
I'm going to guess it's less than one.
How many
Zero.
times have you
Would be
intubated?
zero.
How many times have you intubated people outside of your outside?
Outside.
Outside of a building, outside in a yard, in a truck, in a bed. How many times? No.
Goose egg.
Also,
0 times.
if you're a physician also who is, transferring patients out, they need something other than propofol. I'm
Oh
going to
my
say that
God.
a little louder.
If you
but
try,
gently get the propofol away from me.
if you try to send a hemodynamically unstable intubated patient with a crew and you tell them to just bolus the propofol when their sedation starts to wear off,
I'm going to have a freak out.
you have to come with me.
Yeah.
You're in
Exactly.
timeout. You must witness this. That's
you
your
must.
punishment.
You must witness what you have done.
What this is about to ensue.
Mhm.
I'm just going to read this real quick. Okay, so this is an abstract from a PubMed article from 2021. Succinylcholine is a depolarizing muscle relaxant that has been used for rapid sequence induction and for procedures requiring only brief duration of muscle relaxation since the 1950s.
Oh.
Red flag. Okay, the drug, however, has serious side effects and a significant number of contraindications. With the recent introduction of sugamatics, which is, like we talked about, that's what we give to reverse rock. In the United States, a drug that can rapidly reverse large amounts of rock, succinylcholine should no longer be used for endotracheal intubation.
Hell yeah.
And its use should be limited for treating acute laryngospasm during episodes of airway obstruction, given the numerous risks with this drug, and the excellent ablation of airway reflexes with propofol, lidocaine, and large amounts of rocuronium that can now be administered even for anesthesia of short duration. The use of succinylcholine for endotracheal intubation should disappear from clinical practice.
That's amazing. I love that.
I agree. What the F is going on, guys?
I've always thought, since I even was in medic school and I learned about paralytics and didn't know nothing, I thought it was weird then. I was like, wait, so this drug...
It's so bad,
and the
but
way,
use it.
Yes, and the way they explain it is it's a just-in-case drug. It's if you miss. And I'm like, I feel
Yes.
like that's not what we should be preparing for.
I know, I
The just in
completely agree.
case, if you miss, is called a crike.
That's literally the point, guys.
So don't miss.
Commit to the bit.
Yeah.
All right? Not the bit of using sucks, because that's
No.
deranged.
You have got to be confident in your choices.
Also, this says following succinylcholine occur in both children and adults. Cardiac arrests they're discussing, okay?
Mm-hmm.
There are many cases of hyperkalemic cardiac arrest in patients with stroke, spinal cord injury, burns, and immobil. Okay, how many neuro patients are we intubating?
Honestly, that is like what
Get-
you just listed is the majority of what we are psi.
That freaks me out, guys. So basically, we are all deranged if we're running around saying we should use sucks. These conditions are associated with an extrajunctional proliferation of acetylcholine receptors in a skeletal muscle, which causes an exaggerated release of potassium from skeletal muscle cells following the administration of succinylcholine.
Mhm.
And in some cases, because succinylcholine is so short-acting, if something does go wrong, you may need to give an additional dose, and this study showcases the dangers of additional doses and the increased morbidity. What is wrong?
Why?
They can't read.
Why?
I fear they can't read.
I fear they cannot.
We do have a literacy problem in America.
We do.
I just
We
was.
do. If you're listening from another country,
It's true.
our reading ain't good.
Help.
Oh, there's even more, guys. I'm learning stuff right now.
This is real-time learning.
Raised intracranial pressure in response to succinylcholine can be mitigated by defasciculating dose of non-polarizing and by normalizing the partial pressure of carbon dioxide in the arterial blood following intubation. How are we going to do that?
Use
How are we
rocket
gonna do that?
oxygenate.
So we can avoid the intracranial pressure increase if we,
Get a tube.
and we also
Don't depolarize everything.
we don't depolarize everything.
Yeah,
We
now people
also
have
get
started
blood
using.
gases and we have a vent.
That's my favorite. People have started using a non-depolarizing, a less depolarizing dose of sucks. So they do like a half dose. But again, I just feel like that is unnecessary. We have better drugs.
Also, what if I need more? Then you're
Yeah.
adding the extra dose on, and then it's like another kick drum. Okay. Masseter spasms after succinylcholine.
Okay, well that seems like a problem.
That's a problem.
Sounds like a big problem, to be honest.
Okay. I'm just disadvantages. This is table 1. May induce hyperkalemic cardiac arrest in children with unrecognized myopathy, in patients with stroke, spinal cord damage, burns, immobilization, or known myopathy. Number 2, risk of severe bradycardia or asystole when with large repeat or infusions. Prolonged duration of action in patients with pseudocholinesterase deficiency, patients with myalgias, raised intracranial pressure, patients with raised interocular pressure, patients could. This is literally just a list of things.
How many times you've
Masseter
been like,
spasms?
hey, mama, I know you need a tube right now, but do you have glaucoma?
Yeah. Just need
I'm
to
gonna
know
tell
real
you
quick.
she does.
Risk of
does.
malignant hypothermia, lack of efficacy when succinylcholine has been out of the refrigerator for too long or it's exposed to heat. No reversal agent available clinically except for fresh
Time.
frozen plasma.
Oh.
I didn't know that. But let me just tell you guys. How many times is your truck hot? Do you think it's actually lasting the month?
No, have you ever met the summertime?
Right.
Yes, I have, and I love her.
I don't know.
I actually feel like I've been on
But
calls
she makes that truck toasty.
where the patient got sucks and it didn't work.
Mm-hmm.
Dang.
I have no idea, but there's so many problems here. This is just one study.
Mm-hmm. Don't do it.
This is the advantages. They have a number 2 table. Advantages of rocuronium over succinylcholine.
Ah.
This person is just as angry as we are.
Mm-hmm.
They were so
They're
serious they put it to
ready.
paper.
Faster reversal of neuromuscular blockade with the new drug, Sugamedics. I don't even know if I'm saying that wrong, so I'm so sorry. Then spontaneous recovery after sex. No myalgias. No masseter spasms, no malignant hypothermia, no raised intracranial pressure, and no raised intraocular pressure. Those all sound like good things.
They gotta be. Again, malignant hyperthermia is enough to make me be like, maybe we should steer clear. You know what I mean? Like pre-hospitally, especially.
Reading this sentence, I am realizing that maybe we can do a study, because this is the summary, the first sentence. Succinylcholine has a lot of side effects. It is associated with a lot of adverse events.
Guys, our next endeavor.
We will not be more specific. Just
Our
it's
next
not
endeavor
good.
needs to be starting a journal that is just plain language studies.
We
It's
should
just
do
like,
that.
all right, guys, we was in the truck
It was whack, man.
and this was bullshit.
It was
Like this shit just kept
crazy.
going south, so we started studying that shit. And look what we found.
Look what we found. We found that it has a lot of side effects and it's associated with a lot of bad things. It's
It's
big
whack
bad.
as fuck.
Whack as hell.
Oh my god, I love this study.
Approximately 20% of the people were down bad.
We had some side effects as fuck.
This was done by the University of California, Davis Health Department. Ready? Of anesthesiology.
Wow.
Inside hospitals.
Absolutely.
Okay, guys, so I'm just saying,
Listen to the airway.
We rest our
humans.
case.
there's no point. You're doing it wrong.
You're done.
You're done.
Sometimes our cochlea is like my favorite thing.
If this episode brought you value, take a moment to rate and review the show. It helps more providers find us. Follow Life Sirens, join our mailing list for exclusive content, and visit lifeandsirenspodcast.com for resources and downloadables built for the modern provider. And if this conversation made you think, send it to your partner, your preceptee, or someone on your crew, because better providers build better systems.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.